Welcome to Fire Your Doctor with my wife, Dr. Danielle Lockwood.
And my husband, Richard Lockwood.
Hey, we're not firing her, just so you know. Anyway, Danny, what are we talking about today?
We are talking about the anti-inflammatory illusion.
Ooh. I like it.
Sounds good. So this actually came out, little fun fact, actually.
Okay.
The title of Fire Your Doctor came from an Instagram post that I did on this subject, actually.
Okay.
I don't know if you knew that.
I think we said it in one of the, the first episode.
It came from this subject talking about the anti-inflammatory illusion, and Fire Your Doctor came out of that. It was a very popular title during a post I made. So let's start with a quote. Page 72. Richard, a Fire Your Doctor.
We're going to read this smart person book here. Somebody handsome and somebody beautiful I got together and wrote this book. That was us. Okay, 72. Daily NSAID use has become as common to many... Okay, let me start over. Daily NSAID use has become as common to many daily routines as a morning coffee. As a society and as individuals, we're beginning to see the dark side of NSAIDs coming up in the research. Quote, growing evidence suggests that non-steroidal anti-inflammatory drugs, NSAIDs, while able to alleviate inflammation, may damage articular cartilage.
Okay. Let's break that quote down, Richard Lockwood.
Let's see. Well, first of all, we have included NSAIDs, which are non-steroidal, in our conversation about steroids.
Examples of that would be over-the-counter pain relievers like naproxen and ibuprofen.
So
Tylenol is interesting. It's actually a COX-2 inhibitor. It's not anti-inflammatory.
I was going to say, that's my intent.
It has other damages, but in this particular case, it's mostly ibuprofen, naproxen, aka Aleve is the name brand.
Motrin, all those. Yeah, generally.
Those
right.
quell inflammation.
Right. And we've lumped them in because in this regard, they're, would you say, functioning similarly or taken for a similar effect?
Yes.
Joint pain, inflammation.
Pain in general, inflammation. So, yeah, it's what we're seeing is, and let's break this down. When somebody gets an injury, the standard of care in conventional medicine, and when I say standard of care, that is not my standard of care, right? That isn't even the standard of care of naturopathic physicians. It is the standard of care of the conventional medical system. So the standard of care of the conventional medical system is when you have, let's take a sprained ankle or even, elbow injury or,
let's do sprained ankle. Let's
sprained ankle. Keep it simple. Twisted the ankle so bad it is sprained. You might have stretched or did a micro tear on the ligament. You want to RICE. RICE. That's the standard. And what does that stand for? We wrote it down. Rest, ice, compression, elevation.
So to be clear, that would be the normal standard of care, not our standard of care.
Correct. Yes. And then take some NSAIDs. So take an anti-inflammatory, rest it, put some ice on it, put compression, elevation. Those things, those recommendations are actually not in line with how bodies repair.
Okay. So let's talk about, why don't you walk us through, so we've got RICE on one side, and that's the conventional medicine standard of care for like a soft tissue, like a joint injury. So we have RICE. Why don't you walk us through the natural injury and recovery process? What are the stages of that injury?
Yeah. In order to understand the natural recovery process, let's talk about the stages that a body goes through.
Right.
When you have an injury.
Yeah.
Okay.
Little house on the prairie. There's no advanced medicines, no advanced treatment. RICE isn't known. What happens to my sprained ankle 200 years ago?
Yes. So what happens is there's a huge flood of fluid and a huge flood of immune system molecules. In joint spaces, cells. In joint spaces, there's not a whole lot of white blood cells that hang out there. There's actually very little, they're called macrophages or things that, different types of white blood cells that clean up the area of debris. When the injury happens, that actually signals the body to bring in white blood cells and macrophages and things to repair and or to deal with a possible infection that might be going on in that area as well.
Right.
So it's an alarm system triggered, and it goes in and it tries to heal the area. Normally, not a whole lot of fluid in the middle of your joints, not a whole lot of immune system cells in your joints.
Right. Well, and then the other thing I think is that, number one, let's differentiate between connective tissue and, say, like muscle tissue. So
yes,
one of the, for our connective tissue, so cartilage, ligaments, tendons, what is one of the primary or like the key difference between that and, say, muscle?
Muscle has a lot more circulation to it. It has a lot more nerves kind of going into the area. There's just blood,
I was going to say, I'm looking for blood.
There's actual blood.
We're looking for blood. Yeah.
So, yeah. And so you're able, because that makes sense, because there's a constant damage happening to muscle cells when you go and work out. So it's under constant repair. That's how you build muscle.
Right.
But in joints, those are mostly pretty stable unless an injury occurs.
Right. So what we see clinically is we're going to see that in general, muscle injuries are going to repair very quickly. Joint soft tissue injuries are going to take a very long time to heal. And one of the primary reasons for that is that our soft tissues, our cartilages, don't actually have blood vessels. Mm-hmm. So it's like everything that they get, all of the nutrients, all of the body resources that they would get to heal, repair, recover, are all kind of just floating downstream through just kind of interstitial, which is the fluid that's just kind of floating around in your body in between cells.
So that is why... Well, let me just clarify something. Yeah. You said soft tissue. When you're talking about soft tissue in the joint, you are talking about cartilage and tendon and ligament. Yes. Okay, just precisely. To clarify. Yep. Okay.
Oh, I shook the camera.
I shook the camera. My foot went out.
Oh, you shook it. I was blaming myself.
No, we're good.
Okay.
So and that is why we see swelling in the area. So the swelling comes to the area. In this particular example we're using with a damaged sprained ankle, we see that swelling. And I loved what you said when we were talking earlier about this, how the swelling actually then provides a natural cast that makes it difficult for you to rotate your ankle or move in this particular case. So there's already a natural stabilization that the body's going to have, which is why it's telling you not to move around a whole lot.
Right.
It's trying to keep you from re-injuring yourself.
So let's break this down for people a little bit more succinctly. The RICE, so the standard of care. The normal standard of care in conventional medicine being RICE, so rest, ice, what are we at? Compression and elevation. Those are looking to treat inflammation or swelling of that joint, that injured joint. They're looking to treat that as if that swelling and that inflammation is an enemy.
Yes.
We would counter and say that that's kind of an overly simplistic and maybe even bordering on kind of a prideful view of this whole situation, that, well, that swelling's the problem. The swelling started when you got injured. I'm going to get rid of your swelling and I'm going to help you feel better right now. And so there's a certain level of pride to think that I fully understand this situation and I'm the guy to fix it. Where when we look at what else do we know about joints? Joints are avascular. They do not have blood vessels in them. So there's very limited in how quickly they can heal because of how many nutrients they have. So that painful side effect, that swelling, that inflammation in that joint, what if, Dr. Danny, what if that swelling was actually part of the healing process?
Well, it actually is. In fact, as a Christian physician, I believe that God designed the body to do things for a reason.
Well, right. I mean, so
there's an intelligent design. The joke I have is, hey, we were born perfect. What did we do to mess it up? In this case, we obviously had an injury, right?
Yep.
But if your immune system is working correctly and responding appropriately, it would be good to see a little fluid, and it would be good to see a little bit of inflammation. Now, is there a level we talked about where it's so bad and it's so out of control?
As far as swelling
and inflammation, that it might need to be quelled to a certain amount. Managed.
Sure.
Yes, absolutely. Sure. And that goes back to, what does this person's immune system look like? Is it an out of control immune system because it's totally full of histamines and autoimmune and all of this? So when they get just a simple sprained ankle, it overreacts? Possibly.
Could be. Yeah.
So there could be just like an underlying inflammation picture. And when they get that injury, it really spikes it.
Right.
Could there also be a person who regularly takes these medications and doesn't have any sort of inflammation response whatsoever? Right. Yes, it can go the other way too.
Yeah. And so what we're seeing is there's a difference between relieving pain or relieving a symptom and resolving an injury.
Yes.
And so in a way, by relieving some of these symptoms, I'm going to relieve this swelling, I'm going to relieve this pain, we may actually be cutting off that inflow of nutrients and cells into that area to actually heal that injury. And what's interesting is we're actually seeing this play out with both regular NSAID use, as you touched on, and also repeated use of like steroid injections and things like that.
Absolutely. So I think I wrote here. Okay, so yes. let's talk about that. So there is growing evidence, again, that suggests that non-steroidal anti-inflammatory drugs, NSAIDs, while able to alleviate inflammation, may damage articular cartilage. And that is actually a quote from a scientific study. It's in our book. I don't know exactly which study it is at this point, but it is obviously cited in there.
Page 73 of the paperback.
72 on the paperback.
You're 72. Still, I thought we were on this one.
Yeah. So there's growing evidence that this is actually destroying cartilage and NSAID use. So this is how we get to a place of, and I'm going to get to this in a second, of where we hear that term bone on bone.
Yes.
Okay. So the combination of NSAID, chronic NSAID use, or even repeated NSAID use in these inflammatory situations with steroid shots, cortisone shots, leads to, quote, bone on bone, meaning the cartilage and the tendons have started to wear down. And it's just the bone hitting the bone. There's no cushion left.
So in a nutshell, cartilage takes a long time to heal. Inflammation is painful. People get in this vicious cycle where they're taking NSAIDs, or even worse, getting cortisone shots to reduce the pain and inflammation in their joints. But in doing so, they are interrupting this already slow healing process. And over time, that's making it even worse. So it's like it takes a really long time to build up this cartilage and to rebuild that over time. And so the last thing that we want to do is interrupt that healing process.
Yeah, absolutely.
And even we're starting to see this show up in the standard of care, in that now physicians and, basically they are starting to limit how many times they'll even give somebody a cortisone shot.
Yeah.
Because they're like, hey, I can get you out of jail once, I can get you out of jail twice. At some point, you get 3 or 4 cortisone shots, and the research is in. It's not even controversial.
I want to continue with this quote a little bit because it summarizes exactly what you just said. This growing body of evidence corroborates the. Did I say that correct? Corroborates. Thank you. Corroborates the experience of patients worldwide. People have joint pain. So they use ibuprofen to get through the day. Consequently, over the years, the joint pain gets worse, and they have to use even more NSAIDs, creating a vicious cycle. So it feeds into each other because it prevents that repair, that normal repair that comes in.
Yep.
So ideally, the end stage of that would be the inflammation happens, there's swelling, you start to rest, meaning you're not going to go for a run on that same injured ankle. You're going to be very gingerly moving around, but eventually that movement, that slight, easy movement over time is going to help move the fluid that's stuck in that ankle. Your macrophages are going to come in and gobble up. I call them the little Pac-Men, come in and gobble up any of the damaged tissue. You've now maybe seen a chiropractor, or you've seen a naturopathic doctor or a physiatrist or PT or somebody who maybe adjusted around it to help prevent like knee issues or hip issues. And then eventually after the swelling goes down, maybe the ankle itself can be adjusted as long as it's not completely torn. Yep. Maybe you might use something like arnica, which is a homeopathic. You can use it topically or you can use it orally, which doesn't quell the inflammation, but it helps with the bruising and the pain. So there's a lot of different things. Maybe you use hydrotherapy. Maybe you use not just ice, but you do ice and heat going back and forth. Why? Right. We're trying to promote circulation. That is the normal direction of flow of the body, is to promote circulation so that you can promote this proper inflammation and then eventually pain reduction cascade.
Right. And there could be extreme examples in the inflammation where we need to like manage that inflammation response. But also like we were talking about earlier, there's a way though that a certain amount of swelling is going to almost act like a cast. Like it's going to, like if my ankle's all swollen up because I was doing jiu-jitsu over the weekend and I did it wrong, that swelling is going to keep me from hyperextending my ankle joint. Yes. And
maybe if you didn't hit it so hard with the NSAID use at the beginning, it wouldn't lead to that kind of chronic pain pattern that will set in, which then might require something like a cortisone injection to try to completely cut the pain off and bring down the inflammation.
So that brings us to kind of like, maybe I'll put a finer point on this, is that one of the reasons that we did include NSAIDs in the chapter on steroids is that NSAIDs are something of a gateway drug to steroid injections. And what you were talking about is this kind of habitual that basically you get in a habit of using NSAIDs to manage your pain and your swelling in your joints. After a while, it just stops working. And so that leads to higher doses. And then finally it's just not working at all. And then your only next thing would be steroid injections.
Yes, steroid injections.
And then finally surgery.
Well, you missed a step.
Oh, what?
What about opioid use?
Oh, yeah.
Stronger pain medications.
Prescriptions.
To take care of this pain.
Drugs,
Yeah.
And so.
Which don't really work that well.
Yeah. And so, but we're ending in this kind of picture where NSAIDs are the gateway drug that are actually making the problem worse. And it's like this, the NSAID is opening the door to the cortisone, which is opening the door to the opioids, which is opening the door to kind of a lifetime of surgery and joint replacement.
I'll say this to my patients as well. I'm not completely against NSAID use. There's a time and a place for it. It's very specific. Would I rather somebody use NSAID over going to an opioid? 100% absolutely, right? I'm just inviting them to try other methods that are not addicting and also not harming that normal healing pattern.
Yeah.
Yeah.
Well, I think when you say addicting, like in the case of NSAIDs aren't psychologically addicting or physiologically addicting. I would say that they can be habit forming if someone gets habituated to using them as the only way that they can get up and walk their dog.
Correct. So 73.
Yes.
Can I read this? Or do you want me to do it?
Why don't you do it? I talk too much.
The only medical treatment worse for joints than NSAIDs might be cortisone injections. Also, this isn't just my outlying opinion as a doctor on the fringe. The latest research shows that cortisone shots cause joint damage over time. That is quoting a study. Joints are naturally very slow to heal because these tissues lack blood vessels. Lacking blood vessels and joint inflammation allows the body to bring in additional resources to aid and complete the healing. Interrupting that inflammation process by reducing inflammation via NSAIDs or injected steroids speeds up cartilage loss. And this is actually where I was critical on my Instagram, which is there's I will not name names, but since I do regenerative injection, I chat with all sorts of regenerative docs who are, could be MDs, DOs, like whoever. They like to drink a lot. I'm not so much a drinker, but they tend to get a little chatty after they've had a few, and they will actually brag about this, where they will say, well, we just give them cortisone shots until their joints are so bad that they require surgery. So a lot of them are orthopedic surgeons, right? So they want to get to the point where they can do a ankle joint replacement, or, in this particular case, or some sort of fusion, or, something. They want to get to that. So they know, they've looked at the same research I have. They know how damaging these things can be. They know that they can basically get a insurance coverage for giving cortisone shots. So they'll max out the insurance coverage, and then they'll either offer the cash alternative, which is some of them actually do regenerative injection, which we'll talk about in a second. For example, PRP or prolotherapy, prolozone.
Is that starting to get more mainstream?
It's starting to get more mainstream. In fact, a lot of like the PT clinics are now offering it.
Cool.
They charge about 4 times the rate, just so you know. And
it's too bad they're doing it after cortisone, though.
I know. So they're basically maxing out the insurance, doing as many cortisone shots as they can. And they say, okay, well, now your choices are, we can regenerate some of the cartilage with, and they'll blame just the injury on the cartilage loss, not the NSAID use, not the cortisone use.
Right.
Because that's what's covered by insurance. And then they end up, well, we could offer you this platelet-rich plasma therapy, PRP, or a stem cell therapy for somewhere between $2,000 and $10,000 a shot. By the way, insurance doesn't cover it, so you'll have to pay out of pocket for that, or we can do a surgery.
Right.
And this is the racket.
People are going to be afraid of surgery. I don't want a knee replacement. Let's go with the PRP.
And I'm not saying that there's not a time and a place for a knee replacement or a hip replacement. One of my very good friends, it got to the point where she showed me the MRIs and she showed me what was going on, and she never had any cortisone shots, and she was in pain and it was preventing her from recovering. And she's of an age where I was like, I think you need a hip replacement at this point. There is a time and a place for this. However, her other doc was talking about how, well, we got to do the knee and we got to do this. And I said, let me do some Prolo on you first and see if I can't heal up the knee to save you a surgery. And sure enough, I treated her knee one time because she was visiting from out of state. She doesn't live near me. And that, I think within 1 week, she was back walking 4 miles a day.
All right. We got to rewind and tell people what is prolotherapy.
Well, I think that's actually, we're getting there.
Well, no, I know, but you were starting to mention Prolo.
Yeah. So what are our options?
Yeah. So let's frame this in, if we'll remember at the beginning, we were describing the first thing that happens when you get injured is that, okay, you get swelling and your body is bringing in new resources into that injured joint. And then that is creating a condition, kind of a biological condition that is signaling the body to repair that damaged cartilage.
Mm-hmm. Yeah.
If only we had a way to stimulate that healing reaction clinically.
Absolutely, we do.
Tell us more.
I will tell you. I want to make one distinction because I have this in my notes and I thought it was really good. The difference between relief and repair. So in the case of cortisone shots or NSAIDs, that's not there to repair it. It's there to take away the pain to make you think that it's repaired, but it is not repaired.
Yeah.
It's actually damaged.
Absolutely.
Right?
Absolutely.
So now we're going to get into options for repair, which should actually be one of the first line after we talked about arnica and we talked about doing an adjustment or a naturopathic manipulation on an area and like using those non-invasive acupuncture, cold laser. So I could go on and on. So many options to heal pain that are not used. It's just, oh, weird, take an NSAID or come in and I'll give you a cortisone shot.
Yeah.
So now we're past the point of that. maybe there was a tear that happened, or maybe there was a really just bad overstretching of the ligament in this ankle. This is where prolotherapy, which it means proliferative agent, is what prolotherapy stands for.
Prolo, short for proliferate.
Proliferate, meaning to grow, to repair, to...
So proliferation would be like multiplication or increase.
Yeah, increase.
So how does that happen?
So how that happens is it acts almost like a mechanical irritant to the system. So the needle itself actually will irritate and stimulate that initial response that we get in the initial part of injury, right? And then cause a flooding to the area of the macrophages and the repair molecules involved in your immune system. And what's waiting for them there are a few things. So when we're doing proliferative therapy or prolotherapy at my office, we use a couple of agents inside our injection. So we'll use a simple numbing agent like ropivacaine or lidocaine or something,
which also
like
helps
that.
with your temporary pain.
Yes, and that's a noxious agent that temporarily breaks that pain cycle in the area and interrupts this kind of like nagging sensation that's been in there, controls it long enough, but doesn't stop the proper inflammation process. Let's be clear about that. The next thing that's in that formula is nutrients. So it would be in the form of, for example, dextrose, sterile dextrose or sugar, and maybe a little bit of B12. Sometimes we'll use homeopathics in it. It just depends on the case. And I've been using also some ozone. And ozone has been really good at, everybody says it feels like sand kind of moving through. So it helps to disperse the agent and to get into like the little crevices. It's also incredible, like an incredible killer of, viruses and infections or anything that might be in the joint itself. And it's very good at quelling the pain. So I'll add ozone. I'll add, sometimes a homeopathic, sometimes not, lidocaine or ropivacaine, some sort of numbing agent, and then something to feed the cells when they come there, which is usually like dextrose and, things like that, right. B12.
So what's really interesting here is, remember at the beginning of this podcast, we were talking about the swelling being a signal to the body to repair and also something that aids in the repair of an injury. And so what we're kind of doing is we are simulating the conditions that would exist post-injury in such a way that we are stimulating the body to repair itself. So for example, if you sprained an ankle and you took a bunch of NSAIDs, like we forgive you, we still love you, and now it's like it's just never quite been the same, you're still in pain, etc. What if we could go back in time and recreate that kind of like those conditions that would have stimulated your body's natural healing without actually causing a real injury again. Yep. And so with prolotherapy, it's like you can come in every couple of weeks or every month and we can repeatedly kind of simulate an injury. Yep. And so you get 3, 4, 5 treatments, and now we have been able to go through 5 healing cycles.
Wonderful cases that I work on are actually with people who've had previous surgeries in those areas.
Still in pain.
Mm-hmm. As long as there is not a metal implantable thing, a screw or a plate or something like that, we can inject. And even if there is, I just need to know where it is so I don't inject into
X-rays
it. And all of that. However, what happens is there's also scar tissue that forms, right?
Yes.
After the surgery, and that can cause a lot of pain and tightness in the area. And so part of a good needler is that they're able to break up those collagen cross-linkings that happen with scars, which are really avascular, right?
Yep.
And bring in fresh blood and fresh fluid to those areas.
Right.
I have a really great case I'm thinking of at the top of my head, and he's a rugby player, but he older, but mostly played in kind of a master's team, and had a knee surgery when he was in college. And then the last couple of years, it's just started to ache. He's ignoring it. He's a big guy. He's in great shape. But I said, well, I don't know. Let's just do like a couple Prolo treatments on it and see if we can't get the scar tissue. I mean, within one treatment, he's like, I played 2.5 hours. I was out playing everybody else. I had no pain. It was really, really good for him. So it works really great on previous injuries as well, too.
Yeah. So basically, we're going back in time and recreating that repair response without an injury. So it's like, there's no injury or there's no new injury. And so we're like signaling that body, hey, go repair this area.
Yeah. It's
Come
like,
back
I
in 2
like how you
weeks.
said, it's almost like a time machine. We're
Go
going
repair
backwards.
this area.
But
Go
now repair
this
it
area.
correctly, right?
Yeah.
Now repair
Well,
it
and that's
correctly.
more of like getting into like the kind of like art rather than the chemistry of it. So what she's talking about is that the approach angles, the depths as she's doing the injection procedure, that as she does that, she's doing that in such a way to stimulate the cartilage and the ligaments to regrow in an advantageous way versus like a scar tissue way that will be kind of like joining those ligaments together in ways that aren't really going to help you move naturally.
Yes. I do have to give credit. I won't name the person, but I was trained by somebody who's a very good prolotherapist, and she was very hard on me when I was getting trained, and I did a year-long rotation with her, and she also didn't even allow people to train with her unless she felt like they could have that tactile feel. And I think what was helpful for me in doing these types of procedures is I was a dental hygienist. And then after that, I'm also an acupuncturist. So I'm used to putting needles in places, right?
Yeah.
So it is an art, actually.
Yeah.
And it's
Meaning that
you can't just throw juice in a joint, is what she would say.
Injecting in very, very precise and specific places, doing very tactile, like a lot of physical coordination, eye-hand coordination that you would need to do all these like fine movements to work on in dentistry.
Yep. And just knowing your anatomy too. Right?
Oh, sure.
Knowing I can actually visualize at this point like where I am in that particular joint. And so it's an art. It definitely is.
Right.
So let's talk about some other things. I do want to mention this because it's very popular, is stem cell injection.
Okay.
They're very expensive. It's somewhere between $5,000 and $10,000 a treatment. We do not actually do stem cells at our office. I've heard amazing stories of stem cells working really well. There's a couple reasons we don't do it. Number one, we feel a little icky, just stem cells. I don't know. We can kind of mimic the same thing with the body's own fluid by spinning out and doing something called PRP. Right? Where we take the blood. Rich does all the prep for this. So maybe talk them through really quick, just in kind of a layman's terms, PRP. And then we'll distinguish PRP from stem cells in the next like 2 minutes.
Yeah, for a PRP draw or a procedure, what we're doing is we're taking so you come in, we're taking some of your blood, like a couple vials like you would do to like get a normal blood test or something like that. We take those vials and we spin them essentially in a medical grade centrifuge through a very specific series of RPMs and et cetera, and this repeated process. And what we end up with is all of the red blood cells, so all the red stuff, that goes away. And then we end up with more of like the kind of clear, ivory clear colored plasma. And then we also end up with the buffy coat. And then from there, then we spin that down again, and then you'll end up with these very fine crystalline white layer at the very bottom. And those are your platelets. Now, what's super interesting about blood platelets is they actually have, would those be like hormones in them?
Well, they have basically precursors. I'm trying to keep this layman because it can get very technical, but the precursors to make your own stem cells, basically.
Yes. Where I was going is that they also have basically signaling agents to signal your body to heal.
Yes.
So if I get a cut on my arm,
they signal a cytokine signal, which we'll talk about in a little bit.
My platelets in my blood are going to stop the leak. Otherwise, you would literally just kind of drip, 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 and then a week later you would have bled to death because it never stopped. But that's the beginning of the process. So stopping the bleed is the beginning of the process. So I've temporarily kind of stopped that bleed. Now, once the platelets are activated and they've stopped the bleed, they're releasing a hormone or hormones, shall we say, to the body.
Yeah, they're signaling the release of a hormone.
To make a permanent heal to that wound. So what if we could take those platelets and put them somewhere else in the body? So I'm going to take your blood and concentrate out the platelets, and those platelets will signal the body to do permanent injury repair. And then my wife, the physician, would take those platelets in solution and inject them into specific parts of your body that would need healed.
Correct.
And so, yeah.
Well, and the cool part is those can be used to stimulate hair growth. They can be used to stimulate collagen production in the face. In the face. So we actually use them in multiple places, not just in the joint. So it's very awesome.
Yeah.
But the one thing, and I will credit my mentor for this too, is don't take dirty blood from a person who's inflamed and put them back in your joint. Make them earn it. So most of the people who we see for PRP, we put them on an anti-inflammatory plan for a while to clean the blood so that we get the best blood going back into their body.
Meaning that any of these procedures, regenerative injection in particular, all of the regenerative injections are going to require your body to respond to the signals that our care team is giving it. So my wife's going in, she's injecting your knee. I'm assuming that your knee is healthy enough to even respond to that signal. Because I can be pressing the button, repair this cartilage. 2 weeks later, repair this cartilage again. But if your body's so unhealthy and your entire system's so jacked up that it doesn't matter how many times I press the button to say repair, it's not going to repair it, then it's not going to do any good. And so this is why, even with or without an injury, the baseline health that we have, our inflammation level, what are the parasites like, autoimmune, like all this stuff, we've got to have all of these houses in order, and then you can repair really quickly, actually. With treatment,
And we have seen that clinically as well.
Right.
So that's PRP. Stem cells are where they're actually taking, for the most part, they're saying that they're getting them from umbilical cord, from, the babies
that are just born in a hospital.
And they donate the cord blood, and they're taking the stem cells from there. That is great. Just as a Christian, we worry about that kind of tissue. So we just haven't added that into our office yet because we haven't felt comfortable with where they're sourced. We don't know where they're sourcing it from. And maybe there's a company, absolutely contact us. We'd love to hear more about it. But
for us, it's about ethical harvesting of those stem cells. Because there have been literally studies that they were lying and they were getting stem cells from aborted fetal lines, things like that. And it's I don't want to be running around with my new knees on the back of just a tragic event that I don't want to be spiritually part of. I don't want to be part of it with our care team. And it creates a moral hazard where it's something bad for somebody turns into something good for me. And so sometimes there's been cases with, say, organ donors, right? Where it's you could end up with a doctor with a very perverse incentive to well, I guess this person didn't make it, They didn't make it through their motorcycle crash, but now I get a new kidney to give to this other patient. And so sometimes with stem cells, you can run into those things where a negative outcome for one person is a positive outcome for somebody else. And to us, it's a little bit close to playing God. That said, I feel like if there was some kind of a situation where here's the umbilical cord, the baby's born, the baby's living a great life, and you could also use that umbilical cord to help somebody else, we were just going to throw away the umbilical cord anyway. So there could be a world where there could be ethically sourced stem cells. It's just about where we're getting them and how we're getting them. There's
also the use of your own fat cells that actually can be cultivated. You have to use liposuction.
I don't have any fat.
And
that's not true.
They harvest them from their own fat cells. Body. And so there is a place where that can be done. I actually think they brought it back to where NDs can do that again. It's just not something that I'm currently doing or have even time to do, but I've heard that there's very good results from that too. that would be more of that you're the donor for yourself type of a situation. That could be interesting. I just don't know if I want to like do liposuction and all that on people.
I don't think you'd need to. We just need large gauge needles, like get more.
I don't know. So
it'd be unpleasant.
It'd be unpleasant doable. Between prolotherapy, PRP, and adding the ozone to injections. I get a pretty high rate of repair. So I'm happy with those right now. I'm also always learning new things. So I think that would be great.
Yeah. And I think that's the period at the end of that sentence is that right now you're getting such good clinical results from honestly, a lot of times even just prolo, neural therapy, which is related to prolo, but not quite, PRP, that we haven't really felt there's just not a lot of unmet need, like meaning that our patients are doing really good and we're getting very good clinical outcomes from PRP and prolo. And so we haven't really felt the need to pursue stem cells at this time.
Higher levels, yeah. But there could be, I've had patients tell me very good case studies with themselves or family members of those things. So I'm not mocking them. I'm just saying this is where we're at right now.
We're not there right now. There could be a world where we do it. Our main concern would be A, cost to the patient.
That's what I was going to say. Cost. I like services that are cost effective and give you a big bang for the buck.
Yeah, I would say stem cells would be at least 10 times more expensive than PRP. And then, of course, like the ethics of like, do we know that we know how these were harvested? And does that align with our values?
Yeah, exactly. So I think that's a good summary.
Yeah.
One more topic that I want to hit that's in this category of steroids, and we're talking in the steroid chapter, is steroid mimickers is what we're calling them. So they act like an anti-inflammatory agent. They're not quite steroids. They are called biologics is the main category of them. And two of those types of biologics include anti-TNF agents and interleukin inhibitors. So those are really fancy science terms, but what would you need to know? Okay, so anti-TNF means it's against what your body normally does, which is called tumor necrosis factor. So tumor necrosis factor is a type of cytokine. So we heard about cytokine storm last time. What's a cytokine? It's a signaling protein that's produced by white blood cells or leukocytes that signals either inflammation, immune cell activation, and blood cell production. So those are the main things that cytokines in this particular category are doing. Anti-TNF agents include things like adalimumab. I hate these words. It's anything that ends with UMAB, UMAB. And it would include drugs like the very popular rheumatoid arthritis drug Humira, and Remicade, which is also used for arthritis. Those are all anti-TNF agents. And then there's a new really popular drug, which is dupilumab, and that's an interleukin inhibitor, Dupixent. So just something to know in general, and my concerns with them in general is when you inhibit one signal in the body and it's very focused, you have no idea what the downstream effects are. They can work really well and they can have a very amazing advertising campaign. And I've actually seen these drugs, patients will come in and they've been using these drugs and their eczema completely clears. Their asthma is put into remission. The problem is, and these are a few of the side effects, this is talking about the drug dupilumab, Dupixent is the brand name of it. It can increase your risks for upper respiratory infections, urinary tract infections, and combined with antibiotics, we actually saw studies where it causes what's called IFI, which is invasive fungal infections. Those are very difficult to treat. There's very few antifungal agents that can even hit it. And it's like almost like a sepsis type situation or like a blood poisoning type of situation. But instead of it being bacteria, it's a fungus.
Yes.
And so, and then long-term effects are long-term suppression of these things. So long-term suppression of tumor necrosis factor means that you're going to have a hard time. Your body's going to have a hard time if you're taking these agents, identifying and killing tumor cells.
Right. Let's just, let's like break this down. Like, let's put a fine point on tumor necrotic factor.
Mm-hmm.
So it's Tuesday morning. I wake up and I'm going about my day. My body has a certain level of TNF.
Yes.
Right.
It's a cytokine to signal, hey, I think there's a cell that went a little wonky. It's starting to make a growth, a tumor somewhere.
Right. So it could be a potential cancer, something like that.
Mm-hmm.
And so my body is essentially hormonally, chemically on the lookout for these tumors, these potential cancer cells, and then it has a kind of a plan in place to just like when that little thing is just like, if you never hear and you never notice all of the cancers that you might have had throughout your life that got killed on day one. So it's like one little cell pops up and it's like your body's immune system looks at it and says, that cell might be cancerous, let's get rid of it. And it is literally gone and you would need a microscope to even see it. And then it would just be gone the next day, right?
Yes.
And so what could go wrong if I am suppressing this anti-tumor factor?
Tumors.
Oh.
Cancer.
Oh.
So both of these, and this is open.
Well, that's all.
This is open in the literature.
But my skin will be so beautiful, though.
Well, and it's debilitating. I have had patients where the eczema is so bad that it's like they can't even sleep at night.
No, I mean, I understand that. I understand that there's these severe cases.
Yeah. So we want to be, I want to just absolutely be empathetic to that. There are times where I try to just be open. I'm like, hey, while you're on this particular drug, let's clean things out while we've got the advantage of the anti-inflammation so that we can take down the histamine response to their body. By the way, most people who have eczema have parasites. They just do. They have mold. They have some sort of thing that is triggering this histamine response in the background.
Yeah.
So that needs to be treated. They've got gut issues. They've got these things. So sometimes if they're already on that type of a biologic agent, I will let them stay on that as in the background. We are cleaning and we are dealing with the real issue so that we can then eventually wean them off of that.
I agree with you. We don't necessarily have to make all drugs good or bad. What we could say is that long term, this is going to have serious health implications.
Yeah.
Is it necessary to get rid of or to alleviate an acute condition while we work on a better solution? Like, yes. I think where you really start to get upset is where insurance-based medicine would kind of put you on that temporary solution and then be like, all right, problem solved. Call me when you get cancer 5 years from now.
Well, and that's the problem is when you actually ask doctors about this and when you look into the literature, it's very clear. Number one, many of these drugs are extremely expensive. Okay, so we're talking somewhere between $2,000 and $9,000 per infusion. In the case of Dupixent, it's usually an injection. I mean, several $100s, if not $1,000. I mean, they're very expensive. Now, you may not see that because you have, quote, good health coverage, but that's what's being billed out to your insurance. And all of us are going to suffer from that. Really, these drugs are very expensive.
Let's break that down a little bit. You say good healthcare coverage and okay.
Say in air quotes, good.
Yeah. So that good healthcare coverage might pay for you to get $5,000 of biologics injected or via IV. Would it pay for natural healthcare to go through and spend 6 months and honestly, maybe even a lot less money trying to figure out like what has led to this eczema, what has led to this kind of condition?
No.
Okay.
It isn't.
I'm just curious.
The system is not set up to incentivize recovery, full recovery.
Right.
It's set up to
sell expensive drugs.
Be reliant on the system.
Right. GSK doesn't make any money if we're getting rid of your parasites.
No, exactly. And we're seeing that even with drugs that have a little bit more natural spin on them that are helpful. They would rather you take these other drugs, that are going to keep you on it. So to kind of circle back around, do biologics cure eczema? No, they do not.
They'll stop it.
They will stop the signs of eczema.
Yeah.
They will also cause other side effects long term, right? So they are not the curative agent. They can't claim that they're curative agents. They won't. They will just say, well, you may need to be on this the rest of your life. Well, how convenient. You mean I have to keep taking this thing in order to feel better?
Right.
Interesting.
Right. At which point you could be paying like almost like a house payment.
Yep. They do not cure.
For the rest of your life.
And then you have all these other things. So you're getting
cancer risk.
You're going to get a URI. Maybe it's a bacterial secondary infection and you need to take an antibiotic. Okay, now you're putting yourself at risk for deadly fungal infections.
Right.
What if you're already immune compromised on top of that? What if you have other autoimmunes? If somebody has one autoimmune disease, they have others, right?
Right.
So this is it's a vicious cycle. Again, I'm not saying that there's not a time and a place. I've seen eczema so bad on little kids that they can barely breathe. Would it temporarily be worth it to maybe put them on this biologic to bring down the inflammation enough to where we can clean some other things out? I definitely could see a case use for that.
That's buying time.
Buying time. And we talked about that in the last episode.
Yes,
we needed to buy time. It wasn't that we were curing any disease. It's that we needed to buy time.
Yeah.
And sometimes we need to do that and we need to make that decision.
Yeah. And that's heart-wrenching to hear about, especially for a little kid to be in that kind of a position where they've just gotten that sick.
Yep. So I want to read actually Psalms 147:3 today.
Okay.
He heals the brokenhearted and binds up their wounds. God really is a good healer. He is. And he made the body beautifully. God designed the body with the innate ability to heal. Pain is not a design flaw. It's a messenger. And when we mute that messenger, we risk missing the deeper work of the restoration.
Amen.
So I'm leaving you with that thought today. Thank you for joining us. And we'll see you next time.
Yeah.
Bye.
Thank you.